So thanks for the recordings in progress. Renee and LJ and I talked earlier. The good news is there is not a lot of desperately new information to report, which is good. But we did want to kind of talk a little bit about the transition. Everyone saw, Renee kind of pulled it up in the middle of our conversation earlier, that even Dr. Fauci now has said that the US has exited the pandemic phase and we are entering the endemic phase of the, I can't say pandemic anymore, so I guess we'll say of the COVID cycle. And to Dr. Murray's point, yes, the COVID numbers are not great, but they're kind of stably ungreat. They're going up in some areas, plateauing in some other areas. But I think what we're seeing is a couple things. Number one, I think there was a report out yesterday that the estimate now is that over 60% of the US population has been exposed and or has antibodies when they do testing. So as we had kind of talked about, that asymptomatic exposure probably is much more prominent than we even know. Obviously, there are people who are not getting tested, but there is a bigger chunk of the community that has had exposure or mild symptoms than we probably know, which is part of the reason we're moving into this endemicity phase of the COVID experience. Number two, even for those who are getting sick, the cases are generally pretty mild. So we are not seeing huge numbers of COVID hospitalizations. I think across Monroe County, we are up to about 290 or something like that. But interesting to note that more and more we're finding those are patients who are getting hospitalized for something who are being found to have COVID on that routine screening testing. So they are not necessarily being admitted for COVID per se. As far as ICUs, I think we were at 22 patients in the ICU across the Finger Lakes region, which it wasn't that long ago that we had something like 30, 35 that were in the ICU at strong. So clearly from that standpoint, we're seeing a diminution of the severity of illness, if not a diminution of the hospitalizable illness altogether. So that part is certainly good. The other thing that came out, I think, in the last 24 hours was that there was a kind of more of just an observational assessment that the response to Paxlovid has been quite good. That is, that has become more available and more patients are getting access to it. That at least from an observational perspective, people were saying they were getting better faster, that they weren't experiencing the same duration of symptoms and certainly were not progressing. Now, some of that is because this does not seem to be quite as severe a strain, but some of it does seem to be that the Paxlovid is working even in that high-risk population. So from my perspective, and I think LJ kind of said it best, we wanted to kind of take a pause because this is really the first time in 2 years that we have moved out of the pandemic phase. And even those in the higher plateaus are saying that, to some degree, we kind of get to take a breath and say, thanks for everything that you guys have done. It's been hell in so many ways. But I think for our group in particular, we were talking about what does this mean for us going forward for these calls? What does this mean for the conversations? Because I think if there's one thing that, at least from my perspective, that we've kind of taken away from all this is that the community sense that we have built from these webinars and these communications and the contacts is far better than we've ever had as a medical community, certainly in my 20 years here. So there's something to be said for that. And it's almost a little sad to say that, maybe there would come a day where we wouldn't do this. But I think the other part of it that we all kind of realize when we're talking through this morning is there's now the next phase, which really has very little to do directly with COVID anymore, but more of the repercussions. And specifically, I'll use dialysis as an example that we were talking about this morning. Because of the Great Resignation, because of people moving into travel contracts, because of people who are leaving healthcare and retiring early, using dialysis as an example, Strong has become the de facto hospital in the region that if you had a patient who had acute kidney injury or may need dialysis, many of the community hospitals certainly do not have 24/7 nephrology support, but most do not have the ability to do inpatient dialysis. So those patients almost de facto have been transferred to Strong over the years, to a lesser extent Highland and regional, but predominantly Strong. Just this week, the discussion was Strong is so decimated in dialysis staffing that they're not going to be able, except under the most extreme cases, to be able to accept those transfers on the routine. So what does that mean for all of us? That means our patients who, and again, I'm just using dialysis and acute kidney injury as an example, our patients who used to leave the hospital with a potassium of 3.8 because they got dialyzed every other day and got 4 hours of dialysis, now may be leaving the hospital with a potassium of 5.1 because they're getting abbreviated treatments or they're getting it twice a week because there's just not going to be the presence of service. And that same thing is going to actually carry through to a host of other services. We're going to have offices that have restricted office hours. We're going to have hospitals that are going to have restricted numbers of beds open because there's just not the staffing to accept those patients. We're going to see home care being somewhat significantly incapacitated because they don't have the ability to operate some of those extended services that they offered for years, such as our heart failure program that we co-developed with them, or the COPD program that we were developing at the time right before the pandemic. They're trying just to deal with the patients who are leaving the hospital who can't get to nursing homes, much less do some of these other expanded operational programs. So that's going to be a change, and in some ways a change for the worse for healthcare delivery. Now, we are not unique as a community. There are other communities that are experiencing far worse changes, but it's also not something that we're going to recover from. I think I shared with you guys before that when we looked just within the U of R, within nursing, at the vacancies that we had, if we hired every graduate from every nursing training program in the Finger Lakes region for the next 5 years, we wouldn't be able to backfill the number of nursing vacancies we have today. So we are not going to be successful in hiring 100% of every graduate. And we don't have 5 years in some cases to rebuild all these programs. So there's going to be this new normal where we are going to see some diminution in services or change in service delivery where it won't be as prompt, it won't be as thorough, or it won't be as comprehensive as what it was before. So I think that is something that for this discussion, even though it doesn't have anything to do with the COVID strain that's prevalent or how many patients got diagnosed yesterday, it is a sequelae from this pandemic that we are all now going to have to function under, and it's going to change kind of our day-to-day practice. So I think some of that is kind of our hope going forward of what this conversation may look like, is what are the service issues that we're experiencing? What are the opportunities or what are new service areas that are popping up that can supplement or backfill some of these programs that we've become dependent on over the years? And then if there are new anticipated issues, what can we expect? What can we be looking for coming in the weeks ahead? I can tell you from a nurse hiring standpoint within the hospital, our vacancy rate is actually going up. It's not going down. And the vacancy rate is going up largely because folks who are nearing the end of their working life are deciding to retire early. Some people are just leaving healthcare altogether because they're fed up, they're frustrated. Some people are deciding, you know what, it's summer, the kids are going to be out of school. I'm going to take a travel job for the next couple of months and try to bank some extra cash. So we're actually not catching up. We're actually falling a little bit farther behind. And so that's going to have repercussions, much like the dialysis example that I called out before. So I think finding where these pockets, and I hate to say, there's going to be diminutions in service level kind of across, even in our own practices. So it's not that it's going to be unique to different service lines, but there may be service lines that get especially hard hit that, in this call, we can at least call out and maybe even start to do some of that load balancing ourselves as we talk about where are pockets that actually have that service available that we might be able to redirect. Not that we want to, ship patients across the state, but if we find out that, one of the affiliate institutions, is not experiencing the same shortage of staffing in a particular department and they have capacity, maybe we can start directing in that way so that, it's no longer a pandemic response, but a sequela of the pandemic response, I guess I would say. And then, I think more and more the goal is with you guys, if there are issues that you have, maybe we don't have all the answers, but we can at least be a sounding board. So if someone else has figured it out in their practice, we can kind of share those best practices, or where capable, we can kind of take it back and see what operational efficiencies we can find or bring back to the group to share if no one has any grand solutions. So I think this call we kind of see as kind of being an evolution for right now. The plan would be, get back together probably in a couple weeks and kind of hash this out. But at some point, we've already started talking about, is this going to be appropriate to move to a once a month kind of engagement? Because we want to be respectful of folks' time as well, and not just as much fun as it is to come on and listen to us. I can only imagine that you might have a couple other things in life to do. So there's that. I have seen several side questions on the side of here about satellite lab collections. And LJ, you may know with the school, I'm not aware of any prioritization that's going on right now, but you may know far better than I do.
I can say in terms of the school prioritization, I think that's referencing the fact that, children, school-age children were taking like a little higher priority level in terms of COVID testing. They were sort of right just under the hospitalized bucket. And I think that still is in place, but I think there's just not been the same volume at all of COVID swabs. So I think it's less critical. I would say if it's, I think that they're calling that out in many ways because of they were doing some calling back of information to schools and reporting. They're not doing that piece anymore. We had resolved that. So keep your reporting as simple and straightforward as possible is what I would say. And most of it's being teased out by age. So I don't anticipate that, I hope that won't change actually. It's still going to be an important thing, I think, in terms of more rapid turnaround, but most kids and families are using the home tests or else are coming into your practices and getting testing, on site done. And in terms of the outpatient labs reopening, I do not know about that in terms of outpatient locations, but that is the kind of information we could bring back to you. We can do some investigating. Yeah.
And I will say, as recently as this morning, I believe, to the purpose of the additional lab collection stations reopening, the mainly pathology, but laboratory in general, is also experiencing such a shortage that they are starting to farm out some of their, or what previously was done in-house. They're sending out some specimens for processing at outside labs, which, one, that's because they don't have the personnel to run the test. But two, it also means that for some of these things that were done locally that we were kind of accustomed to the resulting happening much more quickly, we may see another 24-hour delay in some of these tests as they're going to send out labs and being resulted and sent back to us. So because of that, I would actually be surprised, not that it's the exact same personnel, but I would actually be surprised to see more lab collection stations and all that opening, because I think every, phlebotomists in particular, med lab techs in general are in extraordinarily short supply, and even travel companies don't have them at the moment. So I just don't know that there's going to be personnel to open a lot of other satellites. So my guess is the answer to that is no, but I have not heard that per se. So we can take that back and confirm to be sure. So from my perspective, the only other additional piece, and only because it flashed across my computer screen right before this, and so I looked at it briefly, that there is some discussion about childhood boosters coming available towards the end of summer or in the near future. So I think we're going to be hearing a lot. There's been a little bit.
I'm listening to them.
Oh, you are?
Yeah.
There's been a little bit of pushback recently that the Moderna 5 and under vaccine, that the submission has slowed, that the data is actually good from what everybody says, but that the full submission to the FDA has been not as rapid because they're trying to kind of check the boxes and be thorough about it. That has obviously led to some critique that it supports the anti-vax arm of this if we take too slow a process of it, if we think that the data is good. So yeah, I think we're going to continue to hear about this, especially in regards to kids, because there's so much hesitancy in some corners to vaccinate kids. And especially as we're seeing more and more exposure, people are going to revert back to we've got the natural exposure immunity versus the vaccination immunity. So I do think we will probably see boosters for the existing vaccine eligible children. And I do still think that the Moderna 5 and under will be forthcoming soon, but I don't think either are imminent in the next couple of weeks by my read of the TV. So with that, I will shut up and hand it over to LJ.
I'm glad you brought up the booster piece and the vaccination for young kids, Chad. We're just going to have to see where that goes, but it highlights a point. In the PED space, I only have 2 things to mention, and one of them has come from a question from one of our primary care providers, and I think that all of the anybody on this call who either has very young children or knows people with young children or is caring for people with young children knows that it's a mess in the young age, the childcare age group, because parents are having to miss work all the time because of still being, many, many little kids needing to be out for COVID exposures. And there hasn't been any move towards a test to stay type of protocol in childcare settings. And that question was raised by one of our pediatricians, but I think it's a good one. And so we're kind of going back around to the county, to the state, to the whole schools reopening task force group that has not met in a very long time now, of thinking about these protocols and procedures, right? We have protocols that make you pause for the very smallest of symptoms, and yet we have no mitigation strategies in place. And so there's some kind of weird disconnect in this space that I think we need to take a look at. So we'll bring more information back to you, but I think that that's a very real problem still with not having the young pediatric vaccine. The other thing I just wanted to update is that, to Dr. Murray's point, we are still seeing COVID and our numbers are not great. Just an update from the Children's Hospital, there actually has been an increase in children who are COVID positive in the Children's Hospital. There had been, I think, 1 or none over the last few weeks, but in the last week there are 6. All of those are children who were in room air, not in the PICU, although there was one case, a new MIS-C case in the last week, which is really the first one that our Children's Hospital has been involved in for the last 2 months. So these things still exist. We're not seeing the incredible peak or, surge as we had worried about, but they are still out there. And I think we just still need to be thoughtful and careful in our work together. So I just wanted to add to what Chad said. I think I'll just tell a funny story. So my alarm went off this morning, and then I, by mistake, wore my iPhone watch to bed, and my iPhone then buzzed right after my alarm. And it was buzzing a lot. Like I was thinking, oh, now what's wrong? Somebody's sending me a message, must be something wrong. It's not the right attitude to wake up with in the morning. And my watch sent me a message that said, how are you going to show up today? And I was like, what? And then it was mindfulness message. I'm like, my watch is sending me mindfulness messages? Like, I didn't sign up for this. But it made me think for a minute, because already I was irritable and annoyed and thinking like the worst possible thing. And so I decided I would show up today, at least on the surface anyway, thankful. And I really mean it. I am so thankful for all of you, for the work that we've done together during this ridiculous and awful time. And I'm really grateful for the AHP team. And I'm just really grateful for Chad, because there are many times over the last 2 years where I would come on this call feeling like scared about what was going to happen next, or like openly tearful. Like I remember a couple of times having to shut my screen off because I was so upset about things, or just like irritable. And Chad, your attitude is just like a lot of joy and a lot of irreverence, and it's just a really good thing. And Renee, for keeping us together in this space. I think it's really good for us to continue these meetings in some capacity. We welcome your feedback about cadence for that, and if that feels like the right thing for you. But even though the announcement is that COVID is over, we got a heck of a lot of work to do together. And I think the only way we're going to have a good impact on this is by doing that work together. So I just wanted to say, to my watch, I have shown up thankful, although I'm a little irritable still deep down inside, but I'll just cover that up. Thanks, everybody.
I'm kind of upset that LJ's watch is so encouraging. Mine just said, "You're not leaving the house like that." Like, holy crap.
And
It
there's
looks like
just
there
one
was
question
another
in the chat.
question.
Yeah, do we know if the case of MISC was vaccinated or not?
It's a great question. That was from Mendon Peds, I think, right? I was just looking at it. The majority of cases have not been. I cannot comment on that one case, but I can absolutely go back and find out. I don't have that piece of information to share, but we know that the vaccination is incredibly protective against MISC. So again, it doesn't prevent infection, it prevents serious disease or consequences of infection. So I'll find that one out for you and we'll share that. Okay.
LJ, just maybe this was discussed at another meeting that I missed, but I'm just wondering, I just want to make sure everybody knows about the hepatitis liver alert stuff.
Go ahead, Liz. That's great. I don't think that was discussed. Good point.
It doesn't appear to have anything to do with COVID, but just something for everybody to be aware of. Hopefully everybody's received the notification from the state health department, but looking at cases of children having non-hep A, B, C letter associated hepatitis. And so it's case reportable now. And so if you look at the CDC website or the New York Department of Health website, it'll explain the reporting function and on all of that. But basically an unexplained, a lot of cases, severe hepatitis been seen now. I think we're up to many states. It started only 9 kids in, I think, Tennessee, and then some kids in Europe. But it's now in 21 countries, I believe, but they don't exactly know why. There's some thought that maybe it's related to adenovirus 41, I think, not the adenovirus that's used to make the vaccine, in case anti-vaxxers start saying something along those lines. There is definitely, I will say, an anti-vax movement to try to say that it's somehow related to the vaccine. The kids in England who had it initially all were unvaccinated against COVID-19. So it does not appear to be related to that. But anyways, if you come across a case of a child with severe jaundice, it is reportable. Thank you.
Thanks for adding that, Liz.
Now we have a whole new pandemic to worry about, the magical adenovirus hepatitis virus pandemic. Then Dave's put in any guidance regarding which kids are candidates for Paxlovid, which most guidelines have been fairly vague regarding kids with asthma or IBMI. I'll let the pediatricians fire first if there's any guideline. I will say a lot of it initially was around limiting it to only the sickest, and that was just because of the shortage of the drug. Now that the drug is much more readily available, I think the restrictions have been, if the doc feels that the kid is, or the patient, I shouldn't just say kid, is appropriate, then they can just go get it. So I don't think there's any particular restriction at this moment.
I'm trying to remember, I guess, is it approved for 12 and older? I guess it is approved for 12 and
It's
older,
12 and over,
I think.
if I'm
Yeah.
not mistaken.
They're huge pills. I would say that's going to be like the first restriction, is they are gigantic pills to take. But I'm not aware of any pediatric specific guidelines.
I am not aware of that either, but we can certainly, Dave Topa, great question to bring forward. We could do a quick outreach to our colleagues in Peds ID and just check in to see if there's any other specifics they would add to that and get back to the team. But I'm not aware of any specific restrictions. I think it really was all very much around the availability and prioritization.
And then since we're talking about all the butterflies and rainbows going on in the world, if we don't have enough to worry about in our lives, there's been another outbreak of Ebola. Yay! This one is in, I think, the Congo. There's 143 cases or something to that extent. So just when you thought it was safe to go back in the water, the eat your face off pandemic will come again. So
well, at least that's an interesting one with, like, bloody nipples and stuff like that, and not just like boring old sniffling and
if your eyeballs won't melt, then what's the fun of it? That's what I so, something to look forward to. So cancel your summer vacation plans to Central Africa if I were your tour guide, but do as you wish. Anything else from Renee, Jana? No. Any other concerns, issues? Otherwise, we will plan to reconvene in 2 weeks. And then from there, if all is still stable in the world, as LJ said, feel free to share if you have kind of what you would like to see the evolution of this become, whether it's just evolves to not bothering me anymore at lunchtime, or, hey, we'd really like to see more of this, let us know. But if all else stays the same within 2 weeks, I think most likely we'd be looking to go to, maybe no more than every 2 weeks, maybe once a month kind of discussion, but we'll kind of take all that feedback back and talk about it and see what we can come up with. All right. I see people disappearing, so that must be, it is time to call it a day. Thanks, everybody. Have a lovely.
Thank you.
Bye-bye.
Bye.